People, I think the first thing is thinking about for the application to the U.S. Right now, when people come from West Africa to the U.S. and they have a fever and other nonspecific symptoms, there's a lot of urgency to rule in or rule out Ebola. One of the ways people are doing that is they're finding alternative diagnoses, and malaria being one of them. But I think the message here is co-infection is actually common. Michael had reported up to 50%. In our experience, it was probably 10 to 30% of folks who not only had Ebola, but also had malaria. So it's important that it's not a diagnosis that you can exclude Ebola from if they're in the States and you have a positive malaria antigen. You can't simply say this is not Ebola. You need to keep looking for it. The flip side is in West Africa, what we do is for anyone who's sick, we just treat empirically. And then I think the third part of malaria to consider is the traditional way we diagnose is we do a thick smear. That actually can't really be done by the laboratory in a safe manner in all U.S. hospitals. So there are other technologies that you can use, such as rapid antigens. The performance of those tests are variable and less so than I think for other diagnostics, but the strategy needs to change on how we're going to do malaria diagnostics in the U.S. hospital for these patients.
Well, and certainly anybody who happens to contract malaria here in the, Ebola here in the United States, we don't need to worry about malaria co-infection in those patients. My point was just to also make during the presentation was that these patients who are evacuated from West Africa should have been taking malaria prophylaxis while they were in West Africa. And we just want to make sure that people remember that as they care for these patients, they should not neglect to continue their malaria prophylaxis as they would for any returning traveler.
Right. As a follow-on for that, I think that's an excellent point. So doxycycline, which many of the healthcare workers use for malaria prophylaxis, you need to take for 28 days after you return. So it's somewhat onerous to keep remembering about that. Atovaquone is
only a few days.
Is 7 days, I think, afterwards. So both need to be considered, but doxy really, folks need to be very vigilant in making sure that the malaria prophylaxis is continued out through the point of time where they're at risk.